Welcome, my name's Stuart, and I'm going to be running through some of our perspectives as charity of people in this sector and where our work sort of crosses over in the prostate cancer space. So I come from OUTpatients, who may previously known us as Live Through This, so we're the UK's LGBT cancer charity. And I'll be touching on considerations for our community with prostate cancer. So I'll go over some basics around terminology as an introduction. We'll touch on gender-affirming care and then think about investigations and treatment, patient experience, and then also as a charity, what it is we actually get up to. So just to introduce the way we talk about it, so LGBTIQ plus is the sort of standard initialism that we use as a charity. So this incorporates LGB, which is sexual orientation, lesbian, gay, and bi. T for trans, so that's relating to gender identity. We have I for variations in sex characteristics, so people who are intersex. Q, which is queer reclamation of a slur, which is much more popular in younger cohorts. And then plus for others, which may include people who are asexual, pansexual, etc. I won't have time to talk about everybody in the community today, but this gives you a view on who sits under our LGBT umbrella. So if we start with some sort of basic points about sexual orientation. So it's important to note that the census data that we got around sexual orientation disclosure actually might be an underestimate of the amount of people we have in the community. And I say that because, yes, you could take this as a population average and average out all of the age groups over time, but actually you'll start to notice that you potentially are underrepresenting the younger cohorts who are disclosing LGBT status at a much higher rate, and also potentially covering the fact that, in my opinion, people in the older cohorts, so 65 and up, it is likely that there is a similar level of LGBT identity. It's just whether they feel safe enough to disclose this. And you can see this in relation to varying scores of disclosure across different surveys, which have different levels of trust. So, for example, if you compare the census and the ONS to things like the GP patient survey administered by the NHS, which I have here. Then the other interesting thing to see is that in younger populations, bisexuality is the sexual orientation that is becoming the most prominent in our disclosure data. And this has been a trend over time. So you can see over the last 5 years that the move towards higher levels of disclosure, and this is a population average again, so all age groups collapse into each other, but you can see that there has been that steady increase. And again, notice that red line for bisexuality being the one with the most prominent increase. But of course, some people will always prefer not to say, and that's absolutely within their right. So when we think about these populations and we think about the numbers of people, it's always worth thinking about people who don't feel safe to disclose, or potentially we're not using the right language to reach them. And you can see here some data we have again from the GP patient survey about those people with particularly high prefer not to say responses when they are asked about their sexual orientation. So if we sort of have looked at sexual orientation and then we look at trans status, again, you can see a similar factor where by age, there was a much younger sort of lean to the data and much higher rates of disclosure. But again, it may be the fact that there are similar numbers in the older populations, but whether they feel safe enough to disclose this, or again, if they're using different language and terminology. Also, as well, if you break this down by gender, you can also see that there is a pretty consistent trend as well. So it's definitely something to be keeping in mind of, not just for the future cohorts and generations that will come through healthcare, but potentially the unseen, unheard ones that we're currently treating now. So trans status on the electronic patient record then. So why is it that I'm looking at the GP patient survey rather than telling you actual national numbers? So the reason is because trans status isn't routinely collected, despite attempts to try and get this sort of moving in relation to electronic patient records, because many systems still lack a way to record it. Although we do have a method by which we see in NHS standard surveys, so it's been approved, it's unfortunately not really been brought into the actual databases in a meaningful way, at least. So this has been an ongoing issue for some time. In 2018, the Government Equalities Office actually recognised this as a point to be working on and committed to making this data much more available. But unfortunately, those commitments were abandoned in 2021, and we haven't really seen much of a meaningful pickup or goal around this aspect since. And this is important because that data is really, really central to us being able to provide person-centred care. but also because if we are just leaving this on the presumption of people either using their own best judgment to try and identify trans patients or assuming that those patients will identify themselves, we leave ourselves in quite an impoverished position. So a piece of work done by Alison actually showed that for oncologists, at least, asking about sexual orientation and gender identity, about only 5% asked about sexual orientation, 3% about trans status, and 2% were asking about pronouns. The other aspect that you might possibly have as an issue of this, again, is if you are making assumptions on who is trans, either by their gender expression or whatever, then again, you run into a bit of trouble because it might be the case, for example, you're not asking questions that are necessary, for example, potential for pregnancy before radiation exposure, because you don't have the appropriate data or the patient isn't identifiably trans to you. So what is it to be trans? So it's when there is an incongruence, so a mismatch between someone's sex and their gender identity. So sex being those genetically sort of related factors of someone's personhood. So would that be biological or physiological, typically defined into sort of male and female categories, but we also do have people who are intersex, who have a variation of these factors. And then you also have your gender identity. So this is more of the social experience of gender, the way someone might identify and present their behaviors and norms in a way that we typically think about as masculine or feminine or potentially in the non-binary space. So this mismatch, as I said, is called an incongruence. And this was a label that was introduced by World Health Organization to really try and sort of reestablish the way we're thinking about this so that we move away from pathologization and we move into an aspect of this being an actual feature of human experience, much in the same way we've seen sexual orientation move away from pathologization. And you have a quote directly here from WHO where they do say trans-related and gender diverse identities are not conditions of mental ill health, and classifying them as such can cause enormous stigma. So that's true not only in the way we discuss them, but also how we code them in our data sets too. So just to provide additional clarity, so for a person who's cisgender, this is the majority of the population. So there is no incongruence between someone's sex registered at birth, which I have on the top line, and their gender identity, which is on the bottom line. And I've handily put in these dashed lines where if the blue line crosses the orange dashed one, there is a potential for incongruence and that person might identify themselves as trans. Some people might say, well, why do we need cisgender if it's the majority? But in the same way that we have labels like straight and heterosexual, it's useful to know who we are talking about and who we are not talking about, especially when we're talking about person-centered care. So, as I said, majority of people, cisgender with no incongruence. But for a trans woman, this would be someone who was registered male at birth with their sex and their gender identity is female. So again, you see that incongruence there. For a trans man, the opposite would be true. So registered female at birth, identifies as male. And a non-binary person will be either. So it's a case of either sex at birth, but they identify their gender outside of what we typically think of as male or female. So when we do plot gender on a model, you may have seen that there's a couple of different models to do this, like a genderbread person or unicorn or other things that are out there. But typically what you tend to find with these models and many others is they often place masculine and feminine or male and female as extreme points on a sort of bimodal scale, and therefore assuming that everyone's going to slide between those things. And in my opinion, that's unfortunately a little bit of a simplistic viewpoint, because what it does is it starts to make an assumption that people who are non-binary are going to exist somewhere between that line and potentially need to express a level of androgyny, which isn't always the case. So in my view, it's much more helpful to think about it as a triangle or a prism or something along those lines. So when you're then thinking about a gender spectrum, you move away from the aspect of it just being these 2 points of male and female, and you're able to bring in things like third genders, which are evident all around the world. There's multiple examples of these, whether it's the Hijra, the Bernesha, the Mushe, across the globe. We have countless examples of third genders who are not only able to have their behaviours coded as distinct from male and female, but in some cases legally protected as such as well. So with that being the case, it may not be the case immediately here, but it absolutely is globally. Then it allows us to think of this in this gender spectrum, as it were, with some recognition that some people may not have any feelings associated with any of this, and they typically come under the label agender or no gender. So in this prism, you can start to think about then, what does it mean to be non-binary? So again, before when we were just on a line, those non-binary people had a very small sort of section halfway between the male and female points, but actually the reality is non-binary experience is much broader than that. And once we open ourselves up to that understanding, therefore we can think about those people who may present their gender or express it differently than potentially we would expect. So if we go away from all the theoretical and we move away from the taxonomy, as it were, and think about the individual themselves. So I'll start with gay, bisexual, and other men who have sex with men. So there's a couple of points I want to make in this. So this comes from either aspects we have read, direct interactions we have had, or direct patients we've supported. So multiple different sources of information to come to these points. But one of the things we know is that Black, gay, bi, and other men who have sex with men are quite often underrepresented in support groups. And that's obviously interesting when you think about the incidence rate for Black men with prostate cancer. We also know that gay, bi, and other MSM have high levels of concern about their sexual wellness and their ability to return to anal sex, whether that be after treatment or whether it just be issues with their relationships and the abilities to talk about that. Because typically they are unsupported in these conversations, whether that be just because people are a bit uncomfortable talking about these factors, or whether the clinical staff don't feel that they are well trained enough to do so. But this can leave the individuals feeling like there's a lot of unanswered questions and therefore frustration on their part as they try and navigate potential changes to their body and function. And because there is a lack of clear guidance, this can preclude them from being able to return to a healthy sex life and sexual practice, which can therefore affect their well-being, particularly when it comes to surgical and radiotherapy interventions as well. So thinking about, for example, surgery to the prostate or removal of it and how that would affect sexual function, not only from an active partner and erectile dysfunction, but also from a receptive partner to anal sex and the potential impacts there, but also thinking again away from the prostate to the rest of the tissue in the area and the potential for anal stenosis and whether this is adequately supported. Typically, sexual advice is given in a very heteronormative manner. It's usually assumed to have an opposite gender partner. And a lot of the available literature out there is very much in this vein. We have recently published a Sex and Cancer Hub, which is available on our website. I absolutely encourage people to go and look at that. We've made a really concerted effort to try and describe the potential impacts from cancer care in a way that focuses on anatomy and sexual activity rather than identity, so people can access whichever parts they feel are relevant to them. But ultimately, despite all these barriers, these people are very keen to connect. They want that information, they want to be involved, they want to meet others, they want to feel like they're not so alone. And I think that's a really fantastic opportunity for us to seize. If I then apply some direct case studies to this, so these are patients that we have seen. So there was one person, for example, who was over 60 and he had a younger partner in the 40s and unfortunately had unsupported erectile dysfunction as a result of prostate cancer. Now, this patient had a pretty difficult time because they were trying to advocate for themselves to get that support, but because of their age bracket, they were told there were no options available to them. They tried to manage this with their partner and expectations around sexual function. And although originally they tried to make that work, ultimately it led to a breakdown of the relationship. But the important factor here is because that person was not able to get that support, their partner did leave, and this led to depression. They ended up not being able to work anymore, and they ended up becoming socially isolated. So it really is important to make sure that we really embrace the facts and impact of sexual function in the patient. In the second case study, this was a man in his 40s, and again, erectile dysfunction from prostate cancer treatment. And the couple had decided to use an open relationship to navigate changes to sexual function. Now, this can't be assumed of every gay relationship, but it is useful to signpost as something to be thinking about, the fact that actually people may find novel ways to explore or compensate for these factors. And again, not to assume a heteronormative viewpoint for relationships and be open to the different ways people might manage these impacts. For trans women, we have done a couple of focus groups in this topic, and there's some interesting things that do come out of here. So one of the things is they generally feel uninformed and unrepresented by the information campaigns that are currently available. Despite this, they do have some awareness of the risk from hormone treatments. This usually comes from the gender identity clinic, but also from their own readings. A lot of trans people are quite well informed about their own care, but again, shouldn't be the assumption. They shouldn't have to be the experts. There's obviously barriers related to the informed choice program because there is no basis for invitation, as it were. And even if it was, it might potentially have the same barriers cervical and breast have. But because it's an informed choice program, how does that conversation start? Is that patient out to their GP? Do they have a positive relationship? Or do they have faith that they will be managed with the relation to potential discomfort they might have around that topic? Because that aspect, that discomfort, which we call dysphoria in trans people, the sort of intense discomfort from a difference in someone's sex, registered birth, and their gender identity, can be quite profound when we talk about prostate cancer, especially when we're talking about, air quotes, male anatomy. And this is also true not just for the sort of clinical aspects that we have to talk about and the medical aspects, but also from the information that is sometimes available. So there can be really profound points of dysphoria, not just from the information and branding of things that are currently out there, but also the fact that these are quite often masculinized as a way to encourage men to engage with their health. But for trans women, this can end up being quite a difficult thing for them to navigate. There's also the aspect then of if they need this information, are they safe to actually pursue it? And again, in doing so, outing themselves to people in the clinical environment. But ultimately, again, there is an opportunity here because for all the people we've spoken to, there's absolutely a desire to get this information, to access it in some way, but just with some acknowledgement of the fact that it doesn't necessarily need to be super masculine for them, and that might actually be a barrier. So here's my third case study. So this is the story we actually got from a radiotherapist where a trans woman had attended for radiotherapy in the clinic. And it was a difficult thing where she was absolutely there, but it was surrounded by men in that space. And that meant that she felt like the odd one out. So the difficult part was she was not able to have any privacy in that space, not only because she sat there with them, but also the fact that her trans status was confirmed by being in the middle of the clinic and going through the same procedures and the same preparation for the appointment. And also she wasn't really able to benefit from the camaraderie that you would sort of gain in that space that she was seeing other people access. Also, the other thing that was noted was that some staff were also purposefully walking backwards and forwards to be looking at the patient curiously. So again, thinking about how that works with the patient and how they feel and whether they feel safe and supported in that space. So again, some things about sexual function. So anal sex after surgery and radiotherapy. So after removal of the prostate, then obviously it can no longer be stimulated. Now, this is specific to anybody that goes through that procedure. I should sort of just clarify that for trans women, after lower surgery that's gender affirming, so vaginoplasty, then the prostate usually remains in situ, so it's still there. But if we're thinking about sexual function after prostate treatment, so after removal of the prostate, this can obviously no longer be stimulated and that can affect sexual function. And also you can have post-radiotherapy nerve damage as well. And again, that point I made about anal stenosis and erectile dysfunction, but a lot of the research is just in gay and bi men. When we look at trans women, there's not a lot of research, but there is some sort of concurrent themes and discussions that are going on. So for example, anal or vaginal dilation may not be that foreign to trans women because vaginal dilation is obviously a part of their maintenance after vaginoplasty. But thinking then, if this is the case, when people are encouraged to do this, or is there a safe space for them to continue to do so, especially if they're an inpatient? What privacy are we providing people? And also, how are we engaging in these discussions? So how do we actually support people when the standard protocols potentially aren't giving us all the information that we need? So a quick wrap up then of what we do as a charity. So we do support patients like this. So they come to our peer support. people describe our peer support in a lovely way. They do think it's queer and inclusive and supportive and so on. So very grateful for that. Then also we raise visibility on this topic. So we make campaigns that we put in public spaces to try and raise that community understanding. And we take it also to community events. And we've also done work specific in prostate with a small sort of scoping campaign with Orchid in the past. So trying again raise that awareness. We do educate professionals, so we like to reach them and just sort of give them some bare bones information just so they have a good structure to base their person-centered care upon. And then we've been described as informative, inspirational, and interesting, and it's that framework they can build upon to further their knowledge and not only support patients, but also hold each other to a good level of care. We've reached quite a few people with this, so very proud to do so, and they consistently rate it very highly. We also do publish information. So in that, we published research done by our colleagues, we published screening information for trans people, we've made different campaigns with different NHS bodies, we've worked with Macmillan to provide the LGBT People and Cancer booklet, worked with the SOR, and so on and so on. So we're really trying to make sure that we support people all across the field.
Hello there, my name is Alison Berner. My pronouns are she and her, and I am an academic clinical lecturer in medical oncology and also a specialty doctor in adult gender identity medicine based between Barts Cancer Institute and the Tavistock and Portman NHS Foundation Trust. And I'm now going to be honing in on the treatment and care of patients with prostate cancer who are trans and non-binary. So first, a little bit of a background to gender affirming care in more detail so that you will see a little bit more about the particular needs of this population. So trans women and non-binary people who were assigned male at birth might have a number of different hormone therapies, though some may choose to take no gender affirming hormone therapy at all. They may take estradiol, so that's a form of estrogen, either as a patch, a gel, or as tablets called estradiol valerate. They may also take a testosterone blocking drug of some kind, which might be a GnRH analog, which is an injection given usually every 3 months, or an oral anti-androgen, which might be in the form of finasteride. You may also encounter people who are taking progesterone, which is not usually standard therapy on the NHS due to lack of evidence, but there is anecdotal evidence that some individuals do feel better on it. Individuals may undergo gender-affirming surgery of some kind, either a vaginoplasty, which you can see on the right-hand side there, which creates a new vagina, which pushes the prostate forward. So the new vagina lies just in front of the rectum and behind the prostate. For some people, that's not the right surgery for them, or they're unable to have that due to medical comorbidities and other conditions. And so they will have vulvoplasty, which creates the external appearance of feminized genitalia, but doesn't create that potential space of a vagina. Some people will choose just to have orchiectomy, so removal of the testes, although that's not currently available as a standalone procedure on the NHS. So how do these gender-affirming treatments affect the incidence, so how common, and the mortality, so how many people are affected in terms of being unwell or dying for prostate cancer? So you can see there a little infographic on the left-hand side from a previous publication, and I've highlighted in particular the effects on prostate cancer incidence. So the effect of depriving the body of androgens like testosterone starves prostate cells. So it actually reduces the incidence of prostate cancer in the trans feminine population. We don't know in detail about the effects of giving additional estrogen. Estrogen was historically given as a treatment for prostate cancer in cis men at the end stage of metastatic prostate cancer. And so it may be anti-cancer in its effects, also because it will suppress the production of testosterone in its own right. Though there is some data to suggest that estrogen by itself can stimulate some types of prostate cancer cells, but the jury is out on that, which is why the infographic indicates that we don't particularly know. And as a result of that, the most accurate data that we have is that the incidence of prostate cancer is about 5 times lower in trans women on hormone therapy than in cisgender men. And those trans women in this particular study were on an anti-androgen of some kind and an estrogen of some kind. There has since been another paper out, though that didn't talk about anti-androgens, and so probably is less accurate in its measure. And so, as I've said, that hormone therapy probably lowers overall prostate cancer risk. And the age at which you start hormones determines how much that risk is reduced. So you're going to have a lot lower risk if you started hormones at age 20, as opposed to if you had your hormones at age 50. But what we do see in the data is that the risk of dying from prostate cancer is higher for trans women. And that's because if prostate cancer is diagnosed in someone that's been on anti-androgen therapy, so a GnRH analog, and their testosterone is suppressed, that cancer is what we call castrate resistant, so resistant to hormone therapy, and that tends to be more aggressive in its nature. And as I mentioned, we don't have great data for people who aren't on that standard kind of hormone therapy, which is most commonly taken, so an estrogen plus an anti-androgen. So for people who are on estrogen by itself or an anti-androgen by itself or lower dose hormones, we don't have really good and accurate data for those individuals and how common prostate cancer might be. The other factor that can contribute to that increased risk of death may be late presentation because of the dysphoria that might be associated in going to a doctor with a cancer in a part of the body that you don't feel aligns with your sense of your gender. So how does being trans or non-binary affect the investigation and treatment of prostate cancer? So here you can see the impact all the way along the diagnostic pathway for someone who is trans or non-binary and might be taking hormone therapy or have surgeries either already performed or planned that are gender affirming. So first of all, thinking about diagnosis, PSA levels, so prostate specific antigen, might be measured by gender identity clinics prior to starting hormones, and a raised level might be an incidental finding, but it might lead to a whole bunch of investigations that might be quite dysphoric and may or may not lead to a diagnosis of prostate cancer, and so it's quite a lot to go through. Anti-androgens and estrogens together will lower the PSA, which impacts not only diagnosis and monitoring, but we don't have good reference range intervals for trans women and non-binary people. And in fact, that is a study that I currently have in the pipeline to try to establish those so that we can have a more equitable diagnostic pathway. And then, of course, as I've mentioned, there's dysphoria of having to go to a doctor with what is perceived as a male disease. And then when it comes to surgery, if you have a prostatectomy, when you've had a vaginoplasty surgery already, then you have an increased risk of fistula formation. So this is an abnormal connection between two parts of the body, so perhaps the bowel and the new vagina or other areas kind of within the pelvis. Prostatectomy will also impact sexual function because that prostate that's lying anterior to the vagina is still a sexual organ. And then if you've not yet had a genital reconstructive procedure, such as a vaginoplasty or a vulvoplasty, having a prostatectomy might then impact whether you're able to have that or not, or your choice of surgery. So in most cases, a vaginoplasty won't be possible, and you'll be looking at a vulvoplasty, which might be quite a horrible kind of piece of bad news to receive if that's the surgery that you had planned. Radiotherapy for prostate cancer also has side effects. So again, radiotherapy given with what we call external beam from the outside damages the local tissues and again makes vaginoplasty too risky to perform. And if you have had your vaginoplasty and you have radiotherapy, then you do have risks of vaginal stenosis, as would be the case for a cisgender woman. Though at least for trans women, very often they will be used to dilating, and so that won't be a new concept for them, but it might be pretty awful to feel like they have to go back to doing that much more regularly than they currently are. And then if the prostate is much smaller after a long-term anti-androgen, then it might not be possible to do brachytherapy, which is when you put small seeds or rods into the prostate to give local radiotherapy rather than delivering it from the outside. So I'm going to talk to you about some cases. So this is Barbara, not her real name. So she was seen at an NHS gender identity clinic and given clearance to start her hormone therapy, but she had a baseline PSA test done, and she was referred to urology, had an MRI, had a biopsy, and thankfully was found not to have any prostate cancer. But this massively delayed her starting her hormones, though she was eventually able to get started with them. And she was, when I saw her, being bounced back and forth because her GP was then concerned about starting her on an anti-androgen, not knowing what the situation was with her PSA and whether we now needed to worry about prostate cancer. But actually, she spotted herself that the reason that her PSA was probably raised was because she'd had sex, and she'd gone through this whole diagnostic pathway for nothing without anybody kind of asking the question, which was really relevant for her. And so all of this was sort of an unnecessary delay. So you can see the impact there for any prostate investigation, not just cancer for trans and non-binary patients. And that leads me on to kind of the point about investigations. So this is data that's actually extrapolated from thinking about anal sex in gay and bisexual men. And actually, there's no really good research on how long people should abstain from anal sex around the times of investigations and treatments for prostate cancer. But there was some consensus guidance, and there you can see on the left what that consensus guidance is about abstaining. And so we actually have to extrapolate for this population from the research or from the collective consensus status in gay and bisexual men towards trans women. Now, if the prostate has been pushed forward with a vaginoplasty, then some of the same rules will apply in terms of when you can biopsy and when you can do a PSA test. But in this case, thinking about vaginal sex, it's still going to stimulate the prostate in the same way. So we need to ask about all the types of sex and sexual activity that might be relevant for patients when they're undergoing investigations. Most clinicians will not have ever had to examine a prostate via the vagina. And so actually doing an exam that way might be of quite limited use because people won't be used to what it feels like. And it's probably better to skip straight to an MRI. But you'll need to let individuals know who are looking at that MRI scan what they're looking at. And you'll need to let the patient know that you're going to have to put their trans status on a form. And they can actually refuse to have that stated. So it's quite important that you know that you need to disclose that information. And then another major concern can be that if a person's gender is recorded as female, then the laboratory may refuse to run a PSA test. And I know many clinicians have had to have lots of back and forth conversations trying to get labs to actually run tests. And all of this can lead to problems and diagnostic delay for individuals. And so on to another case. So this is Vanessa, again, not her real name. She was a 64-year-old lady who had what we would call an intermediate risk prostate cancer. And she had her prostatectomy, but unfortunately had some cancer left behind at the edge of where the surgery was performed. And so because of a possible recurrence in what we call the prostate bed on a PET CT scan, she then had radiotherapy, external beam radiotherapy. And she was then commenced on an anti-androgen called triptorelin, and that was given not as gender-affirming therapy, but as what we call an adjuvant treatment, so a kind of insurance policy treatment after definitive treatment for cancer to try to stop prostate cancer returning. And so she was referred to me at the UK Cancer and Transition Service, which is the service that I'm going to come on to talk about. And her concerns were that she'd previously been self-medicating with estrogen, very low dose, before her prostate cancer was diagnosed, and she wanted to commence that via the NHS. And actually, we could advise her that the safest thing to do, given her age and her risk of blood clots, was to be on a patch or a gel, which is really important, particularly because any cancer recurrence would increase her risk of blood clots. We could agree a PSA threshold with her local oncology and urology teams that would prompt further scans, knowing that estrogen would lower her PSA and that her PSA would already be lower because she was on the adjuvant anti-androgen. And then she really wanted genital reconstructive surgery in the form of vaginoplasty and hadn't been made aware of the impact of her prostate cancer treatment on that. And so we were able to tell her that vaginoplasty wasn't possible, but vulvoplasty was, which was obviously some bad news to break. And we could help her and support her through that. And her other issue was actually poor urine flow. And her local urology team had been quite reluctant to dilate the urethra and help with that because they were worried they were going to interfere with future genital reconstructive surgery. But we could liaise with the specialist surgeons and seek advice so that they were then able to do that locally and safely, which was of real symptomatic benefit to Vanessa. So on to how we better tailor care for patients. And this is where I'm going to talk to you about the UK Cancer and Transition Service, which is a service I run with colleagues from Trans Plus 56 Dean Street at Chelsea Westminster Hospital. And it's a monthly virtual kind of hybrid MDT and clinic. And you can refer to it using the QR code there. And so this is a service that's actually available to anyone gender diverse, so transgender, non-binary, gender non-conforming, who either has cancer now or has had cancer in the past. And where there is a perceived intersection either by the patient or by the clinician between the gender affirming care that someone is having and their cancer care. And it doesn't matter where they source their gender affirming care. That can be in the private sector. They might be self-medicating. They might have previously been under an NHS gender identity clinic, but are no longer. The important thing is if there is a possible intersection and we're able to kind of smooth the care and give advice, then we will do it. And there are huge numbers of cancers where that might be relevant, and I've just listed some of them at the bottom. But prostate, I would say, is either the first or second most common that we see. That they sort of alternates between breast and prostate because those are very common cancer types. And obviously they're sex-related cancers. And so what we offer is to liaise between all the teams involved in a patient's care. They have this hybrid virtual appointment where all the clinicians can dial in. We can fast track gender affirming care when it's appropriate to do so, and we can send out a letter of recommendations to the current clinicians, which can be really helpful to have it written down as a kind of hand holding when people aren't really familiar with gender care. We can signpost to other services, and we can also offer individuals the opportunity to participate in either research or have their cases used for teaching, as some of the ones that you have seen today, which is really helpful towards building guidelines for ongoing education. Anyone can refer, and patients can self-refer, which is really important. And you can see here the referral QR codes. What else? Well, you'll have heard today about outpatients, and we will frequently signpost to outpatients peer support. And through UCATS, we will soon also be able to offer a clinical nurse specialist who the patient can contact. So we'll have a kind of dedicated point of contact. So having heard about all of the challenges for individuals with prostate cancer who identify as trans or non-binary, you might be wondering what you can do in this pathway in order to improve care. And those can be some really simple things. And I'm sure that your mind is already thinking about what you might do where you are to try to improve that care. And one of those things is really about visibility. And I know Stuart will have spoken about some of this already. And so I've taken some subtle examples actually from the Prostate Cancer UK website to show actually just how changing visuals and environment can be much more welcoming. So here are some snapshots of various bits of the Prostate Cancer UK website. You can see it's quite masculine. It's quite subtly blue. Pleasingly, to me, there is representation of people of colour, which I think is really important, and what can be might be perceived as families, partners, but doesn't seem particularly inclusive of LGBTQ identities. And so what I've done is just introduce some very subtle changes. So slightly different imagery with a couple there who are same sex. And actually this is taken from a different cancer website. And so just to try to kind of keep on point with the imagery, there's still a slightly blue hue to it, but it's just not so completely masculinized. I've kind of taken a different tick box approach so that the accent color is purple rather than blue. I've added a bit of hair to the person on the MRI, and I've included people of different genders at their laptops, and just that subtle thing is just that little bit less off-putting. People can just start to see themselves perhaps in the environment, and people will think, do you know what, this service might be slightly more for me, because it's not just about what you say, it's about how you say it and where you welcome people. Have you got a gender neutral toilet in your clinic? Is everything completely blue? All of these things are just a little bit of a signpost to someone that actually they are safe and they're cared for and they're catered for in that environment. And so here are my main takeaways. So affirming care is person-centered care, and we all want to be delivering person-centered care. So we can be trans-affirming in the care that we deliver. Some real basics: respect people's identity, names, pronouns, and you've heard a bit about that already, but that's really the basics. Ask people how they want bits of their body to be referred to, and don't make assumptions about what they will or won't want. Some people experience very little dysphoria, for example. Don't rely on the patient to be an expert in their care. Seek help where you need to, and we at UCATS are very happy to receive referrals and to give advice, and even if we don't see patients directly, and just make sure you're respecting patient privacy when referring to their trans status. Explain why you're asking all the questions that you have to ask. Explain that it's because you want to tailor the care that you are providing. If you need to talk about stopping or changing hormones, I suggest doing it in concert with us at UCATS or the GIC, but have a two-way discussion. And the same goes for treatments that might have an impact on people's future gender affirming care. Please do refer to us if you aren't sure, or even if you are sure, we can offer that little bit of extra support, and we can only be a sustainable service at UCATS if the need is proven. And then advocate for local changes to systems and pathways that might not be trans inclusive, such as things like only being able to order a PSA if the gender on the medical record is male. So that's all from me. You'll also be hearing from two other wonderful speakers today, and I'm really looking forward to being part of the panel discussion for questions.
I'm very excited to be here. I'd like to talk briefly about my lived experiences that brings me to be part of this program. I am part of the LGBT plus community. My lived experiences around health and access to health services has been a journey that I can share. My lived experiences, I'm a survivor of domestic violence, and being part of the LGBT plus diverse community, my experiences has been a challenge, significantly from a diverse perspective. My current professional role is a sexual violence advocate, and I've used my lived experiences to empower and support the LGBTQ community that faces issues around accessing health and health services, focusing on prevention that enables individuals who experience challenges in accessing services to empower and lead their own recovery. When we talk about prevention, we have to look at the need of the individual and the group that these individuals belong to. particularly the intersexuality within the LGBT community, but also not forgetting the trans community. My work is around prevention, but also life-saving conversations. When I look at my work, I consider tailored support in meeting the unique needs of those individuals that make up the LGBT plus community. My efforts has been around support, listening, focusing on their needs, identifying local resources that enable members from the LGBT community to access appropriate health services. Health services that understand the diversity of the individual, intersectionality of the individual, and their needs, but also looking at past experiences. Addressing past experiences can also have an impact on accessing services, particularly health services. My role as an independent sexual advocate is not only to empower, is to support and listen and respond appropriately to past experiences that enables individuals to feel safe in accessing services. There are times when I have to take up the support in advocating for the needs, particularly around challenges around pronouns, misgendering, and perceptions of an individual, particularly men, older people within the LGBT plus community. I have a great believer through my own experiences in recognizing diversity, but also recognizing the experiences of the journey of an individual from within the LGBTI community. And those experiences that enabled me to promote diversity. Promoting diversity is one of the key issues and work of a sexual violence advocate. My work with Prostate Cancer UK is on a voluntary basis in promoting inclusion through a voluntary-led program that enables me to highlight the importance of the goals that prostate cancer aim to address over the next 3 years, looking at tailored support for individuals, working with an organisation that enables the organisation to look at biases, but also look at underlying issues that of understanding of the diversity within the LGBT community. My own experiences as a Black gay man, I'm visibly out there. However, that's not all the case for most gay Black men, being able to be comfortable being visible. And that's a uniqueness that I have developed through my own experiences. However, the importance for health services and clinical services to understand that being able to openly declare depends on the initial response from environments that the LGBT plus community enter and their first interaction with clinical professions. And being comfortable in sharing their experiences, there is an importance to shape the environment that enables an individual to be comfortable to disclose. But disclosing one's sexuality and one's gender in an environment where one often feels excluded is something that I feel is important. And when I say an importance, it's not just the environment. We have to consider our language, appropriate language, to avoid misgendering, avoid mispronouncing. I want to say mispronouncing. Language is important. From an experience of working within the LGBT plus community and being actively involved as a community member, it's often shared their experience of feeling excluded from their first interaction that could derail an individual from accessing a service further. So I think it's important to recognize the language we use and the environment that enable an individual from the LGBT community to continue engaging with services. And it's listening to the individual's need that is a very important aspect of working within the LGBT plus community. Through my own experience, I have to encounter being a male is often confused with masculinity. Masculinity often is an issue or a concern, but also the individual ability to share their experiences is based on the first conversation they had with that clinical individual. I would like to draw on the experience of a survivor that I've worked with recently that found entering the criminal justice system and reporting violence was a challenge, given past experiences. But having the support of an individual that understands, like myself, that understands their journey, that enables them to feel confident in accessing the criminal justice service, like mine, the health services. There are often experiences of LGBT community members who often feel, and this is something that I've seen a theme within my work, is those who live outside of the cities where the local GP is known to the family. And this often prevents a member from the LGBTQ community accessing in fear that they're going to be outed. It's very important to recognize being outed is not a journey that is comfortable for everyone from the LGBT plus community. And at different stages of one's life, that enables one to feel confident in sharing their experiences or accessing services, accessing help and support through healthcare. So it's recognizing specifically how we change the way we approach individuals, looking at closely our own biases, our own prejudices, and recognizing through support with prostate cancer life-saving conversation, we can enable services to look at a diverse way of working with a diverse community. I often feel the importance of diversity around life-saving conversation is very important to promote inclusivity. The significance of life-saving conversation is very much parallel to supporting victim survivors of abuse and violence from the LGBT community, and addressing health disparities, encouraging open dialogue, sharing experiences, learning from the community can only be an important aspect of developing conversations and life-saving conversation. In line with my own experiences, I feel this is an important aspect of training. The importance of tailored training that addresses the unique needs of the LGBT plus community. When we talk about intersexuality, we need to consider the response of the individual in terms of feeling safe to disclose where they're at on their journey. Life-saving conversation is about empowerment, enabling by doing. There's an importance for organizations, particularly rural health organizations, to look at their own diverse programs, their mission statement, and tailoring their mission statement and their values to meet the needs of the LGBT plus community. It's important for the individual from the LGBT plus I community to see that they can be part of accessing health services. And this can only come about from listening and responding appropriately and free of biases that enables the individuals to feel comfortable. Life-saving conversation doesn't just start with the individual being able to access the service. It's the service being able to respond to the LGBT plus community needs and recognize these needs could be different for each and every one of those individuals from the LGBT plus community in terms of support for individuals who are recovering or coming to terms with prostate cancer. As a society, we often talk about support being your girlfriend, your wife, but in the LGBT plus community, we have partners, civil partnerships, and that labels can often disengage someone from engaging with services. We need to consider support within the LGBT plus community tends to be from close friends, people we trust, from churches, from faith leaders. And that's an aspect that I like to share through my own journey.